Welcome, everyone. You are in the right place if you're looking to learn more about how to increase access to tobacco cessation medications. We are going to be talking about the role of pharmacists in doing that. My name is Kelly McEnany. I'm a senior staff attorney here at the Public Health Law Center. It's really wonderful to see such a mix of folks joining today's call. We were just discussing how the participant list is quite varied. We have folks from the pharmacy world, health advocates, public health attorneys. We want to make sure you're able to engage as much as possible in this conversation. So we'll be saving time at the end for questions and answers. Throughout the presentation, as Steph mentioned, you can go ahead and add those questions into the Q&A. And we are thrilled to be partnering with Dr. Veronica Vernon for this webinar, and I'm going to introduce her in a minute. But first, I just want to give you a quick overview of what the Public Health Law Center does and who we are. And for those of you who have been on these webinars before, you can grab another cup of coffee because this will sound familiar, most likely. The Public Health Law Center is based in St. Paul, Minnesota. We would like to recognize that we occupy land in the traditional homelands of the Dakota people. We would also note that we're working with Native communities to reclaim their traditional practices through culturally appropriate public health policy. So this is a picture of our beautiful Mitchell Hamlin School of Law campus. And the full disclosure is I had an option with a winter theme slide that I ignored because I'm still in denial that it's winter and there is snow on the ground. So we'll pretend it's fall and sunny here. The Public Health Law Center is a national nonprofit that works to reduce and eliminate the use of commercial tobacco. We promote healthy food, support physical activity, tackle climate change, and address other causes of chronic disease. Our commercial tobacco control program is a team of attorneys, policy analysts, and support staff working to address public health through the power of law. And this is just a quick graphic on what we do and how we do it. Legal technical assistance is the sort of bread and butter of our work. We provide technical assistance to public health professionals, attorneys, advocates throughout the country. TA includes legal research, assistance with policy development, litigation support, for example, filing amicus or friend of the court briefs in high impact cases. We develop publications and that explain complex public health and policy issues. And we also provide webinars like the one today and trainings that give you more information on commercial tobacco control topics. We do many things, but we do not provide direct representation. We do not lobby. Just a quick note on terminology. We use the term commercial tobacco purposely. We're trying to emphasize the harmful and addictive products created by the tobacco industry, which is different from, and we're not referring to, the traditional use of tobacco by indigenous communities. Tobacco has been used by many Native American communities for prayer, offering, and ceremonial purposes since time immemorial. So when we use the phrase tobacco, what we're talking about is commercial tobacco as opposed to traditional or sacred use. At Public Health Law Center, health equity is in the middle and the center of our work. When we're helping craft public health policies, we consider that people are differently situated. So if you're applying the same policy across the board, it may have different outcomes for different groups of people. So we want to be very mindful of that. And equity is about understanding barriers, circumstances, and conditions that are prevalent in our society. And again, some of you may know this like the back of your hand, but it's worth just setting the foundation and briefly mentioning the social determinants of health as we start out this presentation. These are external factors that help explain why some people are healthier than others and why some people generally are not as healthy as they could be. So the social determinants of health are a range, variety of conditions in the environments in which we live, work, learn. They affect a wide range of health, functioning, and quality of life outcomes. They also include racism, discrimination, and bias. So the social determinants of health help explain in part at least why the leading causes of poor health and death in the US are chronic diseases that are largely preventable: cancer, heart disease, high blood pressure, diabetes, and tobacco-related illnesses. Health equity and the social determinants of health are certainly at the core and the center of what we're going to be discussing today in this conversation about expanding access to cessation treatment. And Dr. Vernon will touch on this a little more in her presentation, which is a great segue to introducing our speaker. Dr. Veronica Vernon is an assistant professor and vice chair of pharmacy practice at Butler University in Indianapolis, Indiana. She received her Doctor of Pharmacy degree from Purdue University and completed 2 years of postgraduate training at the Veterans Affairs Hospital in Indianapolis. After her training, she became a clinical pharmacy specialist where she managed a variety of conditions. Tobacco cessation was a core component of her practice. In 2017, she helped Indiana pass legislation that permitted pharmacists to prescribe tobacco cessation medications through a statewide standing order with the Indiana State Health Commissioner. And that standing order went into effect in 2019. It should be noted that Veronica has worked with two wonderful mentors and leaders in tobacco cessation efforts, Karen Hudman and Robin Corelli, to expand the role of pharmacists in tobacco cessation efforts. And now, without further ado, I'll turn it over to Veronica Vernon.
Thank you so much, Kelly, and thank you to all of you for joining us here today. I am thrilled to be talking about this topic. I think it is an incredible opportunity for health departments and public health advocates to partner with pharmacists and expand our ability to promote tobacco cessation and promote healthy communities. During the presentation today, we're going to start off talking about the state of tobacco use, and then we'll segue into why pharmacists. Just so we all level set, I know there are quite a few pharmacists on this call, but for those that aren't pharmacists, explaining a little bit about background and why pharmacists can have an impact. We'll then talk about the different state policies that permit pharmacists to prescribe tobacco cessation medications, and finish up with some barriers and policy considerations. Since 1965, we have seen over a 70% decline in smoking, which is wonderful news. However, we still have over 36 million US adults and 760,000 middle school and high school students who are using combustible tobacco products. We know that cigarette smoking is a major cause of death and disease. More than 490,000 deaths are due to cigarette smoking or secondhand smoke. 470,000 of those deaths are just due to cigarette smoking. This is a significant concern because this is preventable. These deaths are preventable with tobacco cessation. 5.2 million adults are going to use smokeless tobacco. So we're not just worried about cigarettes, but we need to be worried about things like dip and e-cigarettes and other forms, vaping, other forms of smokeless tobacco. And we know that disparities exist too among tobacco use. Cigarette smoking is going to be higher in Indigenous peoples. 1 in 4 Indigenous peoples in the US use a tobacco product. And we see disparities in quit attempts among racial and ethnic groups as well, where Black Americans are more likely to make more attempts to quit, but are less successful. And this is important, and I'm so glad that Kelly opened us up with talking about social determinants of health, because we see that impact in tobacco use. We see that individuals who have a lower socioeconomic status are more likely to smoke and suffer health-related outcomes from smoking. We also know that this isn't just a problem with adults. Over 2 million middle school and high school students are going to use tobacco products. Among 2023 to 2024, among all middle school and high school students, the use of tobacco products decreased from 2.8 to 2.25 million students, and e-cigarette use also decreased, but we're still seeing it. It's still concerning that we're seeing among high school students, 10.1 of all students are using any tobacco product, including smokeless tobacco. When we think about tobacco cessation attempts, it's incredibly important to note that it's not going to be a single attempt that often makes people successful. And most people want to quit smoking. In a recent survey by the CDC, nearly 70% of adults want to quit smoking. Over half of them have tried to quit in the past year, but less than 1 in 10 are successful. From data, we know that on average, it can take anywhere from 6 to up to 30, according to one study, quit attempts before individuals are successful. I can speak from my own experience managing a considerable number of veterans and trying to quit smoking. that it took several attempts for them to be successful of coaching, behavioral modification, working alongside our wonderful psychologists at the VA to help with behavioral change, as well as working with an interdisciplinary team. That it does take a village to help individuals be supportive and feel successful in their quit attempt, and continuing to ask the question, are you ready to quit smoking? Healthcare professionals can play a major role in intervening with smoking cessation attempts. With help from a clinician, the odds of quitting are going to double. You can see that without a clinician, our estimated abstinence at about 5 months is about one, looking at that. And that's going to double with a physician, a clinician, and it nearly doubles with a non-physician clinician. So this is incredibly important to note that healthcare professionals can make a huge impact in that, and that includes public health professionals. Pharmacists are public health professionals and healthcare professionals and can aid in these efforts. I pulled the recent US Surgeon General's report on the state of tobacco-related health disparities that was released in March of this year. And I specifically looked for when pharmacies and pharmacists were mentioned. He mentioned that getting tobacco products out of pharmacies should be a priority. And we have a couple of folks on this call who've been engaged with those efforts and that research, that is really important. And then the US Surgeon General also says that we need continued efforts to increase access to healthcare for underserved population groups, as well as efforts to expand the reach of cessation interventions by leveraging the full continuum of healthcare settings, including through pharmacists, which is incredibly important to note that pharmacists are in many healthcare settings and have many touch points with patients across the spectrum. The Centers for Medicaid and Medicare Services also put out a bulletin. They first noted it in 2017, and this is from their most recent bulletin on strategies to improve delivery of tobacco cessation services that was released in March of 2024. Point number 4 that you see highlighted on the slide at the bottom says to partner with tobacco cessation quit lines and providers such as pharmacists to increase access to cessation treatments. We do see movement from federal government entities that pharmacists should be engaged in our efforts. We are one tool in the toolbox in order to improve cessation efforts. To get us all on the same page, behavioral strategies are incredibly important for tobacco cessation efforts. We also can couple this with medications for patients that would meet and need therapy for this. Just so we're all aware, we have several different options. We have over-the-counter options. These are available without a prescription in the patch, gum, and lozenge. One thing to note about these is that they're only over-the-counter for those 18 and older. Remember, we talked about middle school and high school students, so they would not be able to go in without a prescription to a pharmacy or other retailer that sells these products and purchase them on their own. They can have a prescription for them. Prescription nicotine replacement therapies, which I will be referring to this as NRT for the rest of this presentation, would be the nasal spray. We used to have an inhaler, but it was pulled off of the market last year. And then we have 2 prescription products that are tablets that are not nicotine replacement therapy. And these would be varenicline and bupropion sustained release. And one thing to note is that these are approved for smoking cessation. I say tobacco cessation, but the official approval from the Food and Drug Administration is for smoking cessation. We will use these off-label for smokeless tobacco cessation as well. Pharmacists have been engaged in a multitude of public health efforts because of their locations. 89% of all Americans live within 5 miles of a pharmacy. Now, we do have more rural areas that may not have a pharmacy within 5 miles, but based off of a study that was published in 2022 that did mapping of pharmacies and looking at where individuals lived, most Americans are living close to a pharmacy. Pharmacists have been doing immunizations for several years, and in all states and Washington, D.C., pharmacists can immunize and provide immunizations without a prescription. By 2017, all 50 states had increased naloxone access through pharmacies, and we see pharmacies gaining prescriptive authority for other medications in several states, such as contraception, testing and treating for things like strep, flu, COVID-19, where pharmacists can do a test at the pharmacy, see that it's positive, assess a patient based off of their symptoms, and safely prescribe them a treatment. This is also expanding to HIV, pre-exposure and post-exposure prophylaxis, and a multitude of other conditions. And it's because pharmacists are accessible. If you think about your local pharmacy, it's probably opened a little bit later than other healthcare settings. It has weekend hours, it has evening hours, that on average, individuals are more likely to go to their pharmacy in a year than they are to go to other healthcare settings. Pharmacists are readily accessible and trained to do this. The entry-level degree for the profession now is a Doctor of Pharmacy degree. This switch was made in the early 2000s. Tobacco education is in required and elective curricula at the majority of pharmacy schools. Based off of a study that a few folks on this call did, that we're seeing it in over 98% of schools. RX for Change is an example of curricula that schools can use. It's meant to be interdisciplinary and not just for pharmacy schools or pharmacists. It's made for all health professions, and it can be used and modified in any health professions training. In 2006, 98% of pharmacy schools had gone through the Train the Trainer program and had been utilizing RX for Change. So this curricula, that's a model for tobacco cessation education, has been in place for several years now and is being used in pharmacy schools. This is something that I'm proud to say that in my home state of Indiana, all 3 of our schools are teaching our students how to do this and giving them comprehensive training. From a perspective of all healthcare professionals getting some training on tobacco cessation, the profession of pharmacy has tried to make a very focused effort to make this essential for pharmacists. Pharmacists do provide effective intervention as well when it comes to tobacco cessation management. There's a variety of studies that have been done that showed pharmacists in a variety of settings, from community pharmacies to physician clinics to even being in the hospital, can help patients successfully quit tobacco products. And they do that just as well, or sometimes even a little more effectively than other healthcare professionals. That's not to pit anyone against each other, but it's just to say that there is a precedent set for pharmacists doing this, and there's data to show that the interventions are effective and that we're also cost effective. So it's not just getting patients to quit, but it's also doing it in a way that it's affordable for patients and the healthcare system. If you're curious to learn more about different settings that pharmacists have worked in for tobacco cessation interventions, the American Pharmacist Association, designated as APHA on the slide, a few years ago put out a report called Promising Practices for Pharmacist Engagement in Tobacco Cessation Interventions. My disclaimer is that one of my sites was listed here. And so this is not meant to be self-promotion, but just to show you that there are a variety of sites where pharmacists work. We have data that pharmacists can make interventions via telehealth and telephone and in-person visits after patients get discharged from the hospital to help them quit smoking. Before we get into state policies, I wanted to discuss how pharmacists can prescribe. I want to think about this like a continuum of pharmacist prescriptive authority. This was coined by Alex Adams and Crystal Weaver first, and then revised with the addition of Jen Adams as an author last year, that we have 2 different ways pharmacists can prescribe. We have dependent prescribing and independent prescribing. Dependent prescribing means the pharmacist is dependent on another practitioner, typically a physician, but it could be a physician assistant or physician associate or advanced practice registered nurse in select states, that have to sign a collaborative practice agreement with a pharmacist. This allows the pharmacist to either see a certain patient, which would be a patient-specific collaborative practice agreement, designated as a CPA on this slide, or a population, so seeing a group of individuals, all the individuals that come into a clinic or all the individuals that walk into a pharmacy. But we are dependent on finding a healthcare practitioner to sign off on that. All 50 states allow pharmacists to do some form of collaborative practice agreements, but it does vary from state to state in what pharmacists are permitted to do. Some states say pharmacists can initiate medications. Some states say pharmacists can only adjust existing medications. Some say pharmacists can't discontinue medications while other states do. And some states put a restrictive on where pharmacists can do this in. They could do it in the hospital or a physician clinic, but not in a community pharmacy setting. I am a proponent of collaborative practice. We need all the different forms of prescribing, but when it comes to our public health efforts, collaborative practice can be restrictive because it requires pharmacists to identify a healthcare practitioner who will sign off on their agreement. And if it's a pharmacist in a community pharmacy setting, this can produce some barriers. Now, there are some states out there. Washington State has been doing this since 1979, the first state in the country to allow collaborative practice agreements, where it's working very well. In other states, finding that practitioner can be really challenging because what we found is that medical malpractice may not cover that healthcare practitioner signing off on a pharmacist collaborative practice agreement if they don't work in the same entity, which can be a challenge. Independent prescribing has two different buckets. Government protocols, which would be a standing order, which is typically a statewide standing order is signed off by the state's physician or the state health commissioner in the states, or the board of pharmacy. So you can have those two approaches. You can also have other forms of government protocols, but it's typically an agency, an executive agency that is permitting pharmacists to do this because of authority they've been designated through their legislature. And then our most permissive form of prescribing is called standard of care. Standard of care means that pharmacists are able to prescribe what they have the experience, training, and experience to do. I like to give the example that I am a primary care trained pharmacist who also has additional training and experience in gynecology and endocrinology. I feel very comfortable in those spaces. I would not be comfortable prescribing in an oncology clinic because I am not trained to do that. The standard of care is used by a handful of states in the US, and that allows pharmacists to prescribe based off of where they're located, what type of patients they're seeing, and what they have the training to do. We'll now dig into the state policies. I got a little into the weeds with you on prescriptive authority, but it is important to note that there are significant differences between these four buckets. There are 20 states that have permitted pharmacists to prescribe outside of a collaborative practice agreement. You may be looking at this because we have attendees from all over the country, and you may say, well, pharmacies in my state can prescribe and we're not listed on here. They're likely using collaborative practice agreements. I mentioned Washington State being the first state to allow it. They have over 33,000 collaborative practice agreements on file with the Board of Pharmacy, which is amazing. Pharmacists can do a lot with CPAs there, but collaborative practice agreements vary from state to state. And so my focus is what states allow pharmacists to do this independently, either through a state health commissioner standing order or a statewide protocol. The statewide protocol would be a protocol that the Board of Pharmacy in those states create and sign off on, and it applies to all pharmacists in those states. They have to usually follow certain education, documentation, and other requirements to follow that protocol. You can see that the statewide protocol is the most popular version. I will give the note that in California, they use the term furnish. In other states, they will use the term that pharmacists can prescribe or order. California just uses a different term, but it's meant to have the same intention. In addition to what state policies we have, we also see differences in what medications can be prescribed by pharmacists. We don't have equity across the states. That we do have a state that allows pharmacists to do this through a standard of care approach, but it only restricts them to over-the-counter nicotine replacement therapy. So Maine doesn't have education requirements or other requirements for pharmacists to do this, but it limits pharmacists to over-the-counter nicotine replacement therapy only. Over-the-counter and prescription NRT are seen in a variety of states. This is designated in states in the lighter color. And then all medications, which would include our over-the-counter and prescription nicotine replacement therapies, as well as varenicline and bupropion, are going to be in the majority of the states. And we'll talk more at the end about which approach is going to be recommended based off of expert opinion and the literature. What's exciting to see is there has been a growth in tobacco cessation prescriptive authority for pharmacists across the years. New Mexico has the distinction of being the first state outside of a collaborative practice agreement to permit pharmacists to prescribe tobacco cessation medications. They did this in 2004. We then had over a decade where there wasn't any movement until 2013 when California passed a law allowing pharmacists to furnish tobacco cessation products. And this went into effect in 2016, which is why California is designated with the 2016. Arizona, Colorado, and Idaho followed in 2017 with their implementation. Indiana, we passed the bill in 2017, but it took us a couple of years. We had a change in state health commissioners. They were both wonderful, but we had a change, and so we got it implemented in 2019. And then you'll notice that there are a few states that are in a different color: Kentucky, New Hampshire, Ohio, and Tennessee. This is because they pass specific laws allowing pharmacists to prescribe tobacco cessation medications, but the caveat is, in those 4 states, they still require the pharmacist finding a physician to sign off on the protocol. So the protocol is approved by the Board of Pharmacy, but they still have to find a physician in the state to sign off on it for that pharmacist to do it. So that's why these 4 states weren't included on the other maps. I'm going to dive into a few of the states now. This is not meant to be exclusive by any means. I picked a few states that have taken this route to talk a little bit more about what they specifically require for pharmacists in their state, just to give you an overview of different state approaches. I started with New Mexico because they were the first state to allow pharmacists to independently do this. They do it through a statewide protocol with the Board of Pharmacy. If pharmacists meet the requirements of the protocol, they are able to prescribe. When it comes to education and training requirements, they say that pharmacists must follow the U.S. Department of Health and Human Services, Public Health Services clinical practice guideline for treating tobacco use and dependence. They specifically call this out, and other states have used this language, which is why I highlighted it here. New Mexico requires pharmacists to follow some health screening requirements, so they have some requirements that pharmacists have to ask patients about their health screening, as well as requirements for what the pharmacist needs to counsel or tell the patient on related to tobacco cessation treatment, and then requirements about documentation and notifying their primary care provider if the patient was seen by a pharmacist. We're going to highlight my state here. This is the state that I have the most experience in, so this is why Indiana gets a little bit more face time. Indiana has a state health commissioner standing order. We're one of the few in the country for smoking cessation products. So it is for smoking cessation products, but I'll talk about on the 3rd bullet point how we didn't limit this to just cigarettes. Training, documentation, and follow-up requirements are required in Indiana. So according to the State Health Commissioner's standing order, there are things that pharmacists have to follow. One of them is taking a continuing education course about smoking cessation treatments. One thing that I wanted to highlight that after this protocol went into effect, we actually had to go back and amend, was that this protocol specifies the criteria and procedures to assist pharmacists in providing safe and effective tobacco cessation therapy in Indiana. This includes cessation of e-cigarettes or other devices used for nicotine. We wanted to make sure that pharmacists in Indiana could do cigarettes, smokeless tobacco, and that could include vaping, which is incredibly important. Our standing order is highlighted on our Quit Now Indiana, which is our quit line for the state. They have been wonderful partners, and they actually have a whole section of their website devoted to pharmacists being able to do this, where they post the standing order from the state health commissioner. So it's very easy to find and read. I like this quote from Dr. Christina Box, who is our immediate past Indiana State Health Commissioner. Smoking is a domino for bad health outcomes. We want to remove as many barriers as possible for people to get help. And this is featured on the Quit Now Indiana page on the pharmacist section. And this is what Dr. Box said when she signed the standing order back in 2019. Indiana was also featured in a case study. The American Lung Association have been great partners. They've helped with us in our state and other states to talk about how we can expand the role of pharmacists in tobacco cessation. After Indiana, some of the folks from Indiana, including Dr. Hudman, worked with Vermont to get them a Board of Pharmacy approved protocol. And Vermont requires pharmacists to have training and education in the area sufficient to perform the duties involved. So this sounds like pharmacists need to have the education training to do this. They don't specify what kind of education the pharmacist has to do. They also require the pharmacist does some specific health screening questions. They require what the pharmacist has to document during the visit and after the visit, what counseling they have to do, and then when the pharmacist needs to follow up with the patient. We're going to shift gears here just to show you a different way to approach the prescribing piece through legislation. Montana took a very broad approach. Montana said that pharmacists may prescribe a drug or device for conditions that do not require a new diagnosis, which could be for tobacco cessation, are minor and generally self-limiting, are diagnosed by or for which clinical decisions are made using a CLIA wave test, which would be a point of care test that can be done at the pharmacy or wherever the pharmacist is in that setting, or for patient emergencies. So they can prescribe for these 4 conditions. You don't have to meet all the criteria, just one. So this is interesting because in Montana's law doesn't specifically call out prescribing for tobacco cessation, but they took a broader approach. And this is actually language that originated out of Idaho, which is our next state we're going to talk about. Idaho started in 2017 by putting into law that pharmacists can prescribe tobacco cessation products. They put in some education requirements and documentation requirements in the law. They then changed to the language you just saw on your screen from Montana, that Montana adopted, but Idaho was the first to do it. And now Idaho has shifted even broader to say that the practice of pharmacy means all of these things listed and prescribing of drugs and devices as may be further defined in this chapter. How the Board of Pharmacy approaches this is they say that a pharmacist can prescribe for any condition as long as it's not prohibited by law, either federal law or state law, or prohibited by the rules of the Board of Pharmacy. It's consistent with the individual's education, training, and experience, and performance of the act is within the accepted standard of care that would be provided in a similar setting by a reasonable and prudent individual with similar education, training, and experience. This is how Idaho was able to get to this broad approach. They took a stepwise approach, and they also had the standard of care legislation in place saying that pharmacists do have to follow guidelines and do what any other pharmacist or other healthcare professional would do in a similar setting. So I think this is important, and this is a very crucial piece to stress that pharmacists are following the same standard of care that other healthcare professionals would for tobacco cessation. What are the barriers we see when we're implementing these policies, and what are some potential ways to navigate? I am always happy to share from my personal experience on if we were to go back and do this again, what we would do differently. Barriers that have been cited by pharmacists in the literature have been time, payment, pharmacy workflow issues, pharmacy software issues, the variability of state policies, and the limited scope of policies. We're going to start with talking about time. Time is incredibly important. I'm sure some of you have seen in the news or experienced yourselves that community pharmacies appear to be understaffed and be under increased pressure. This is a concern. And so you may be thinking, how can pharmacists even add this to their workflow in a community pharmacy? We're going to talk about some considerations for this. One of those pieces that feeds into time is having the payment for this. Other healthcare professionals, when they see patients for tobacco cessation services, can bill insurance, and they can charge a fee for this service. Pharmacists are not recognized as medical providers by most insurance plans in some of our states. Some states have passed legislation requiring pharmacists to be recognized as medical providers who can bill the same codes as other healthcare professionals, but we don't see that as a uniform approach. And pharmacists are not considered medical providers under the Social Security Act. And so we cannot bill Medicare Part B, as in boy, for our patient care services. We just can be billing Medicare for drugs and what we call medication therapy management. Pharmacy workflow feeds into these other things too. How do we work this into our busy time? And then with software, the consideration is, can my pharmacy software document? And if I can bill for this service, can I bill medical insurance? Because our pharmacy software systems are set up to do pharmacy benefits management billing. We're meant to bill for the product, not the actual service of providing the counseling and education to patients. We also see variability of state policies. This can be a challenge for pharmacy entities that are multi-state. So typically think of our chain retail pharmacies that are located across state lines. It can be difficult for them to roll out tobacco cessation services if they have to follow 50 different sets of regulations and laws. And we also can limit ourselves sometimes with our policies and make it too narrow, and that can be challenging for implementation. We're going to put time, payment, and workflow together in one bucket. It's important to note that there's a great toolkit out there. I mentioned RX for Change earlier, but they do have a toolkit on how clinicians can implement tobacco cessation services in a variety of settings. And they even have this specifically for community pharmacies. One thing that has been recommended by several researchers and experts in the field is to utilize pharmacy technicians. Pharmacy technicians work in our community pharmacy settings, among other settings, and will be doing the technical tasks in the pharmacy. They can enter data, they can process insurance, they can fill prescriptions, all under the supervision of a pharmacist. You can include technicians in workflow and encourage pharmacies to, hey, you should have your technicians start asking if patients are interested in quitting and help promote your service. Help patients fill out a questionnaire if they're interested in more information or want to speak to a pharmacist. Pharmacists not being recognized as medical providers by all insurance plans can be a challenge because you're not going to have the time and resources to implement this service in a busy community pharmacy if you're not able to get compensated for that time. If I have to step away from what we call the bench where the pharmacist works to talk to a patient for even 10 to 20 minutes, if I'm not able to bill for the use of my time to see that patient, it makes it very challenging to create a sustainable service. Some considerations would be to collaborate with your state Medicaid. Indiana State Medicaid is an example of a state that's been offering this as a service for some time. It's not been widely implemented because pharmacists have to implement a whole billing system for just one service. So it is important to work with Medicaid and see, can we pay pharmacists for the same services that we would pay other healthcare professionals where there are established billing codes and it's within the pharmacist scope of practice in order for pharmacists to set up a billing system? You can also work with commercial payers through your relationships to see if there is a way to get commercial payers on board with this. We've seen several states now pass policies that either require commercial insurers or Medicaid to allow pharmacists to be credentialed and contracted with health plans in the states. This has been positive movements. As more states do this, we're seeing more payers being receptive to this idea and understanding what pharmacists do. One thing that you can also do is connect with your local state pharmacy associations and your pharmacy employers in the state. This includes your health systems. Health systems can be wonderful collaborators with this. They often have outpatient pharmacies and they have pharmacists working in the inpatient setting that can help promote tobacco cessation services and work with patients. But your state pharmacy association is going to be able to help connect you with other key partners in your state. And if you're interested on where you can connect with state pharmacy associations, you can visit the National Alliance of State Pharmacy Associations website to locate the State Pharmacy Association in your state. Software is really important, and one thing that I've been involved in discussions with in other states is how can we connect pharmacies with our state health information technology systems? Is there a way that we can start to share information across pharmacies and health systems with that? We still might be a ways off from that, but we're getting closer, especially with some national health IT efforts. You can also collaborate with your state pharmacy associations and pharmacy employers. One of the most important things you can do when passing policy is if you want documentation requirements, talk to your pharmacy partners in the state and make sure that this is feasible for them. How do they get their information? What can they document? What do they need for software upgrades in order to do this service and to have holistic quality documentation for tobacco cessation visits? When we create state policies, broader is going to be better. In order to make it as broad as possible, in order to avoid any unintended consequences of making it too narrow. This includes limiting restrictions on documentation. So one example could be a state said you have to use this specific form as a screening form for patients for tobacco cessation visits. In theory, that's a great idea because everyone's using the same form. It's standardized. However, not all pharmacies can use that form based off of their pharmacy software and their technology. And if every state says you have to use their own created form, this creates a problem for companies that are across state lines and trying to implement this in more than one state. It's also important not to limit this to the site of care. One thing in Indiana we had to do was to clarify with the Department of Health that pharmacists who weren't in a dispensing role in a community pharmacy could also use the standing order. I worked in a physician office for several years. Could I use the standing order under the state health commissioner's name and send a prescription to a pharmacy? And we were able to clarify that that was included and under the intent of the law. Also thinking about your follow-up requirements. Several states do this. Can you make your follow-up requirements broad? Does the pharmacist need to see the person in person, or can they do a telehealth visit or call them, or can it be up to the pharmacist and their professional discretion? Also, one thing to think about is age. Some states limit this to 18 and older, but we do have middle school and high school students who want to quit smoking. The American Academy of Pediatrics does recommend nicotine replacement therapy for those who are wishing to quit under 18. Is there a way you can collaborate with pediatricians in your state to create a policy that works for all, where we can increase access to tobacco cessation services? I also want to stress, and cannot stress this enough, to include all medications in state policies. Just having over-the-counter nicotine replacement therapy isn't going to move the meter as much as we want it to move. Just including over-the-counter and prescription nicotine replacement therapies isn't going to get us there either. We want to have all therapies available, especially varenicline and bupropion. We do know that in some studies, varenicline can be the most effective options. Nicotine patches plus bupropion can also be incredibly effective. And we want to make sure that individuals have access to the treatment that's going to work for them. I often had to switch between several modalities for my patients, and it was nice to be able to have the freedom to do that. Finally, when you're crafting state policy, or if you have existing state policy, make sure that you expand this, that it includes cessation of all tobacco products, that we're not just focusing on cigarettes, but we also allow pharmacists to help manage smokeless tobacco products, such as electronic cigarettes. When you're passing these policies or revising these policies, who can you work with? When you want to work with pharmacists, go to your state pharmacy associations. Your board of pharmacy in your state can also be a helpful starting place, especially if you're working for a state agency, to get you connected with your state pharmacy association. Typically, the boards in most states will not be able to take an opinion on legislation. Some of you work for state departments of health and probably navigate this well. You can also work with public health organizations, both at your state and at the national level. Groups like the American Cancer Society and the American Lung Association have been very helpful to work with and get ideas from. They have also published information on the role of pharmacists in tobacco cessation and have those available. And we will be talking about an exciting new resource that the Public Health Law Center will be putting out later. I will let Kelly and defer to Kelly and Stephanie for more information on that. Employer organizations can be incredibly helpful too. They want their employees to quit smoking. We know that that can help quite a bit with healthcare costs that are rising for employers, and you can collaborate with them to gain their support for policies. And then finally, consumer advocacy groups can be incredibly helpful in increasing access and choice for individuals in your state. This is a great website that my colleagues have created, quitsmokingpharmacies.com. This can show you about pharmacies all across the country that have signed up to say that they provide smoking or tobacco cessation services. You can use the locator map to find a quit smoking pharmacy in your area, and patients can use this, consumers can use this. There's also some nice frequently asked questions about the pharmacist's role in helping people quit. It also provides you and other clinicians and organizations with the ability to identify where to refer your patients to, and consumers and constituents in your state. So please visit this website. I will say it's a self-enrollment system, so we are continuing to encourage pharmacies across the country. My colleagues are through their research and dissemination efforts to get pharmacies to ensure that they are listed in this directory. I'd like to acknowledge Doctors Karen Hudman and Robin Corelli for their research. They are incredible advocates in this area. I know at least one of them is on this talk as well, as long as a few of their colleagues who do wonderful work in this space. And they are the reason I'm giving this presentation today. So I'm very grateful for their support and work. Now we'd like to take any questions.
Wow, what a wonderful presentation and so much information to cover. You did a great job getting through so many pieces of it, and we have lots of wonderful questions to match. So I think what we'll do is kick it off with, let me just quickly mention, thank you for that shameless plug, Veronica, for us about our new publication that we're going to be releasing, Challenges and Opportunities for I think it's prescribing smoking cessation products, challenges and opportunities. So that should be within, don't hold us to this, but probably this week, possibly next week. We're excited. It's just a Q&A that will, sound familiar after this presentation and follow up on some of those concepts and ideas and information that Veronica shared. So, but yeah, I think we have so many that we'll do our best to answer them in the limited time we have. And to the extent we don't reach all of them, we can certainly circle back with folks separately. And we're seeing a lot of good questions about challenges in certain states and certain circumstances, which we also might follow up separately on, just to let folks know. I did want to start, I think one of the questions I think we've gotten that we've heard, and you touched on this a little bit, but how can public health professionals engage the pharmacist? Where do we start? How do we make this, the lanes merge to try to be most effective?
That's a great question. And I have experience in this area. I think one of the best things you can do is reach out to your state pharmacy association. I see a few folks on here that are heavily engaged in their state pharmacy associations to make that connection. We were very privileged in Indiana that our Indiana Department of Health has been an excellent partner and has worked very closely with our state pharmacy association to connect with. I also say, get to know your local pharmacist and work with the colleges and schools of pharmacy in your state. If you have them, there are pharmacy schools and colleges all over. And there's usually more than one, and that can be a great connection to work with the faculty. You can just simply look for the contact information on the website, find a faculty member that specializes in tobacco cessation efforts. I'm happy to provide my email. I know there's a few other folks on this call who do some amazing work at connecting public health professionals with pharmacists in their communities to help make this happen.
Excellent. We have another question that I think is also probably a pretty frequently asked one. Have states that have been successful in implementing this, it's moving as I'm speaking, have states been successful? I think the question was whether there's been pushback from physician associations within the states that have passed this and maybe beyond. So can you talk about those challenges?
That's a great question. And yes, there has been pushback in multiple states. And I think it comes down to, I'll use a term that's been used by another medical organization, that's scope creep. Can pharmacists do this when this has traditionally been the role of other healthcare professionals, mainly physicians? And I completely understand where these groups are coming from with their opposition, but there is so much data to support that pharmacists can safely do this. And in states that have had the opposition, one way to work around it is to identify other physician groups in the state that are interested in this. Your main state organization may not support it, but there might be a few others that do. And you can also work with your public health groups, your other healthcare professional groups. We've seen work with nurses, with physician associates, with other groups that are very supportive of this, and consumer groups to help overcome this. And one legislator, when I was watching testimony in a state, said it best, is that we need everybody on this problem, that we're not going to move the needle, we're not going to decrease the use of tobacco and nicotine products if one healthcare professional is allowed to do this. And there's data to show pharmacists can safely do this, and we can work in tandem with other healthcare professionals. And it's been done in other states very safely. And there have been zero incident reports related to reported to Board of Pharmacies related to pharmacists prescribing these products. Yeah, I see that
there's an
Dr.
echo.
Hudman just put it in the chat. Thank you.
Perfect. Yeah, so, and I was going to ask, one of the arguments is against these policies is safety. Can you discuss the safety of pharmacists prescribing these medications? And I think there's a connection.
Yes. So I just said there have been 0 incident reports. Dr. Hudman and Dr. Correlano have talked to the boards of pharmacy in all the states that permit this. And it's also important to note that there has been pushback, especially when you want pharmacists to prescribe varenicline and bupropion, because some people will say, well, there's side effects with those and there are concerns. The FDA removed the box warnings on varenicline and bupropion for having neuropsychiatric effects in 2016. And that was based off of a large trial called the Eagle study that looked at bupropion, varenicline, nicotine patches, and placebo, and found there was no significant difference in those side effects or any side effects between that. And that was the evidence that partnering with researchers and experts in the tobacco cessation field, that states who've been able to pass all medications have shown and been able to successfully demonstrate that this is completely safe for pharmacists to do. And I like to point to the fact that pharmacists are trained in medications. We are serving as the medication expert on the healthcare team. We're trained in drug interactions. We're also trained in how cigarette smoke can interact with other medications. And so who better to be looking at this than a pharmacist, along with other healthcare professionals? We're all in this together. And I think it's important that pharmacists are another access point, that it's not meant to be that we're going to solve the problem, but we're another access point working with all of the other resources that we have available for our communities.
Absolutely. So shifting gears a little bit, we've got a question in the chat from, let's see here. Have you seen a change in moving from, quote, tobacco to tobacco and nicotine products in terms of legislation and implementation?
That's a great point. I'm so glad you asked that. I see who asked the question. Excellent question. I think that has definitely been a move to it. And I'm seeing now, thank you to Frank, who's another expert in this field. There's nearly 10 states. This is from Frank, that have been pending legislation this spring to allow authority. So this is continuing to grow. And I do like the move to be as inclusive as possible in order to avoid making this too narrow and pharmacists not being able to meet the needs of their community. So I do think we're starting to see a move that way. I think we're going to probably have to work on changing some existing policy, but that's a great question.
Excellent. I think you touched on this a little bit, but maybe to circle back in case there's anything to add. What barriers keep young people, especially teenagers, from accessing nicotine cessation medications? It's a big issue. How can these barriers be addressed?
Yeah, definitely. I think that's incredibly a wonderful question. And I think it's multifaceted. And I know there's some other folks on this call who are experts in this area. And please chime in with the chat. I'm happy to read it out for the whole group to read. I think a lot of it is access. And there's also that concern of having to approach a healthcare professional to talk about it. Who do they talk to? Especially if they don't want their parent or guardian to know. They're nervous about this. Who can they go to? And a lot of it may be that they're not going to just walk up to a pharmacy counter or make an appointment and go into a clinic to talk about this. That some things that can be helpful and what we've seen used in some healthcare settings is having a QR code up on the wall that individuals can scan to get more information and make a decision if they want to approach or fill out a form that can be electronically sent where they can be contacted to get information. But I think having as much signage up in different areas about where adolescents and young adults can go get assistance for tobacco and nicotine cessation and who they can talk to is really important. But having as much signage and awareness as possible is really key, because it can be very intimidating to make that initiation. I think even for those of us that aren't young adults and adolescents, but knowing who you can go to and having visible signage is important.
Absolutely.
I will go back to the previous question because Dr. Corelli just mentioned it, that the California protocol was approved and implemented before Eagle's trial because they were 2016. And the removal of the box warning. This led to the approval of only NRT. As of last month, California is moving forward with the standard of care model, which is very exciting to hear.
Late breaking news. This is great. Okay. So I wonder if there are a couple questions around reimbursement and payment that we might touch on a little more. I think we had a question early on that might have been addressed, but maybe just to make sure there wasn't anything else to add. The law is summarized. I think this is one of the prior slides. Do they include reimbursement? I know in California, this has been an issue, more recently resolved for private
Yes.
insurance. Yes. Okay.
Yes. So in California, they passed that pharmacists could do a variety of furnishing or prescribing medications, and then implementation wasn't great, which makes sense to me. If pharmacists aren't able to bill for the service, they're having to do cash-based service, which I saw another comment about this. That can be a real barrier to patients. And I am always concerned about avoiding creating more inequity, and that if you're doing a cash-based service, that's great for some folks, but it's not going to be great for our folks that are Medicaid or Medicaid eligible, or not able to afford that. And so California went and passed a bill that allowed certain services that pharmacists did to be able to be reimbursed under Medi-Cal, their state Medicaid program. And pharmacists could be credentialed and contracted as medical providers. And so that helped with the Medicaid side. It's not perfect, but it helped. Other states have done that to try to help as well. And then there are some states that have said, we're going to actually require commercial payers to pay for services that are within the pharmacist scope. And we do see that, Pennsylvania is paying pharmacists for cessation through medical assistance. So working through collaborative practice or being able to work through if you're doing OTC nicotine replacement therapy, which is amazing. And so we're seeing more and more states do this, and then getting commercial on board is really key. I believe I will let folks chime in, but it's been a little bit less of a barrier to navigate as more states pass policies saying you need to let pharmacists have parity and let pharmacists be credentialed. It does help. Somebody asked about vaccines. The vaccine payment is a little interesting in how we do this because it's covered under the medical benefit and pharmacy benefit in a lot of plans, which is fine. It makes it easy to bill. But the trouble is with working through the pharmacy benefit, you're working through the pharmacy benefit manager. And that can be tricky if you're trying to get paid for any other service under that. We want pharmacists to start billing under the medical plan for medical services they provide, the tobacco cessation education and counseling, just as our other healthcare professionals would, which is really important. I will read this off. I'm just seeing the chat and I'm trying to monitor it. Dr. Hudman says a new approach we're trying is to layer brief tobacco interventions on top of vaccine administration. We call it give quitting a shot. I love that. That's so amazing. Ask about tobacco use, advise to quit, provide cessation assistance, or refer to the quit line. Brief, effective, and easy to implement for many pharmacies. So that goes back to our workload and time discussion. Thank you, Dr. Hudman and Dr. Corelli for that. Dr. Corelli said, even with Medicare and commercial plans in California, pharmacists are encountering challenges with reimbursement. Billing services is very different from prescription claims. And that's absolutely true, that pharmacies often aren't equipped to do the medical billing. In order to make that worth their time, we have to make that part of our standard workflow. So it's a steep learning curve for both the health plans and the pharmacist. Some health plans are trying to make a separate network of pharmacists, which I really discourage against doing that. Put pharmacists into your medical provider network. We don't want to be different. We want to just have parity.
Fantastic. I think we have time for one more question. And I think what I'll have you end on is maybe what are the most important driving factors for these wins behind implementation in the states with past policies? Like what has been the secret sauce or the magic ingredient?
Engaging in some of the education efforts that Dr. Hudman and Dr. Corelli and their team have done. They have a grant through the National Institutes of Health where they've been training pharmacies and have done an amazing job. And there was a study published earlier this year that showed those that went through their training were more successful in implementing it and having access to those resources. We also see states that are passing payment parity laws have been more successful in getting this off the ground and ensuring that there is the time and resources devoted to do this because of that payment piece. And then states that have made this broad, not making your policy too narrow. Try to avoid putting a lot of burden on pharmacists, a lot of burden on your patients, a lot of burden on the site of care to do this. Trying to remove those restrictions is important. So just making sure that you don't go too overboard with trying to put guardrails on it. Think about what protects public health and safety and what can make sure that this is done and reaches the most amount of patients.
Fantastic. Unfortunately, we've reached the conclusion of the webinar, which flew by. Thank you so much to Dr. Veronica Vernon for the wonderful information. Fantastic questions from folks joining us today. I'll let Stephanie do the honors of wrapping it up and letting you know about what to see in your inbox with the recording.
Sure. And thank you, everyone. Yes, if you asked the question, it didn't get answered, we will try to do our best to follow up via email. Feel free to follow up with us if you don't hear from us in a few days. Thank you to everyone who's been engaging in the chat as well. It's been a really engaging webinar. We love to hear from you in the chat. And then we should have this webinar posted within 48 hours. I should have it up by tomorrow. All registrants will receive the email in their inbox, so you can feel free to share with others or rewatch the recording. We do have an evaluation survey that'll pop up as you exit the webinar. If you just should take you just a couple of minutes, we would really appreciate you completing that to let us know what was good and what we could improve on. And with that, I will let everyone go. Thank you so much. Thank you, Dr. Vernon. Thank you, Kelly. And we will hopefully see you on a future webinar. Have a great afternoon.